Very good morning, everyone. Welcome to yet another ISG Masterclass. Uh, with profound sadness, we inform the members of ISG and other colleagues of Indian gastroenterology and also of global gastroenterology that our beloved teacher, a mentor, and a guide, Professor Rakesh Tandon, has breathed his last on August 3rd of this month. He has been a pioneer of gastroenterology in our country, and he has been a mentor to many of us. We have a couple of minutes on his condolence. And Dr. Rakesh Tandon has been born in 1941, and he breathed his last on August 3. Dr. Tandon carried the legacy of his grandfather, uh, Bharat Ratna Sri Purushottam Das Tandon, who has been conferred Bharat Ratna and in the service of mankind. Therefore, Dr. Tandon carries legacy of his great family as a caring doctor and passionate researcher. Dr. Tandon has been a lead person in the growth of Indian gastroenterology. He established therapeutic endoscopy in our country, and he also established pancreatitis diseases in our country. The All India Institute of Medical Sciences has been his Karm Bhumi, where he served first as a faculty, also as a sub-dean of AIMS, and then as a head of department of gastroenterology. During his tenure, he trained a number of gastroenterologists who are leading the country today. He also played a big role in the growth of Asian gastroenterology, and he has been one of the pillars of friendship amongst Asian gastroenterology. He also led our society, firstly as a Secretary General for 6 years, and then President of Indian Society of Gastroenterology. He had been conferred the very prestigious Viceroy Award by Medical Council of India. He was conferred as Masters of World Gastroenterology Organization in recognition of his contribution to world gastroenterology. He was also conferred Lifetime Achievement Award by Indian Society of Gastroenterology, the Crohn's and Colitis Foundation of India, and of All Indian Institute of Medical Sciences. He also established and has been lead person in the research in chronic pancreatitis and pancreatic disorder as a whole, and he has been counselor for the Indian International Pancreas Club. He had a wonderful writing skill, and he wrote more than 300 papers. He wrote 68 chapters and also wrote many books for awareness about health for Indian citizens. He has been editor of many journals, including Journal of Gastroenterology and Hepatology. Dr. Tandon has been in many of our mind and heart very close, and have been the mentor and guide for all of us. Dr. Tandon has been survived by his wife, Dr. Manjula Tandon, and she's a physician, and his son and a daughter. His son is Manish Tandon, he's a gastroenterologist, and also his daughter, Richa Tandon. He has been mentor, as I said, to many of gastroenterologists, and we pay homage to Dr. Tandon. Dr. Tandon, you will always live in our heart, and we will remember very fondly about you. With this, let me invite Dr. Vivek Saraswat to say a few words. And these are some of the messages which we received from members of ISC and his friends and colleagues from all around the world. We'll compile all of these, and we send this to family of respected Dr. Tandon. Maybe I invite Dr. Saraswat to speak a few words.
Yes, Thank you very much, Dr. Govind. If you could please stop sharing your screen now. Yes, thank you. Uh, Good morning, friends. This is a solemn occasion on this edition of the India ISG Masterclass. As Professor Makhari has just told you, uh, the gastroenterology community is afflicted with bereavement in the untimely passing away of Professor Rakesh Tandon. As Govind has said, I think of all of us here on the panel in front of you, he was the teacher for Randhir, for myself, for Govind, and also was the senior to Dr. Chandrasekhar. In fact, there are our generation of gastroenterologists all looked up to him as the teacher and mentor. I had the good fortune to being a student in the All India Institute and to do my dissertation under his care, getting into biliary microlithiasis and pancreaticobiliary diseases under his tutelage and leadership. The entire uh, direction of careers of many of us have been shaped by his influence, and his passing away has left such a big hole in the lives of many of us that one is hard pressed to imagine how we can ever get used to a world in which we find that he is no more amongst us. With these few words, I request my others on the panel, beginning with Dr. Chandrasekhar, to say a few words in homage to the um, to our teacher. Professor Chandrasekhar, please.
Good morning, colleagues. It has been a very sad day for the gastroenterology fraternity and the community. Last I met him in December in Chennai when he was the guest speaker for Tamil Nadu ISG, where he was the first one to receive Master of World Gastroenterology Organization when Tamil Nadu wanted to celebrate the three awardees, Dr. Tandon, Dr. Nagi, and me. So I had a close talk with him. What I really appreciated in him is his appetite in learning, continuous learning as a student. He was the first one to attend the meeting and the last one to leave the academic meeting. And he expressed his concern that we need to improve our research in India. So you youngsters should go for the multi-centric study and all you pull your data, and they're still ringing in my ears. And the one attracted me very much is his focus of concentration in pancreas. That brought me closer to him. And even earlier, he was ahead of his time in thinking about the single organ focus. So he was interested in pancreatology. And I learned quite a bit from him, even though I was not directly a student. And he is very fond of encouraging the younger community. The three things I can never forget it. I know it's a big loss. The only thing is we can do is we follow the principle for which he lived for, he fought for. And I pray God Almighty for rest in peace and to give the courage to all his students and community and his family members to come out of this crisis. Thank you very much for this opportunity.
Thank you for your words, Professor Chandrasekhar. Now I request Dr. Randhir Sood, one of his mm, prize students from gastroenterology department, to say a few words on this occasion.
No, thank you, Vivek. I think for me, Professor Rakesh Tandon was, like the potter who, shaped my career. In fact, I learned my ERCP from him, and that's the skill I have practiced throughout my career, and made me progress in my career. In fact, the biggest thing about Professor Rakesh Tandon was that he never, treated his students, even if they knew nothing, with contempt. In fact, he was so good. He will always encourage you, and the training in ERCP, how frustrating it can be. He will always encourage you, and he will be a teacher in the hospital, and he will be the greatest of your friends outside the hospital. In fact, that was the quality which I think most of us need to imbibe. And in fact, the other thing which I would like to share is that all of us, many of us, learned how to spend quality life, and improve our, way we live, after, emulating him the way he lived his life. He was always very flamboyant outside. He was, I used to call him Devanand of gastroenterology, and he was so positive and, always cheerful. In fact, I used to share many times morning walks with him, because we lived very close by, and we used to share pleasant social moments together. And he was a wonderful person, and he was the only person who could made me write my first paper. In fact, and that was my one of the biggest handicaps, and he could get me out of that and made me write a paper. Then he could persuade you to do anything. And I in fact want to dedicate this talk to my teacher and mentor, Professor Rakesh Tandon, and may God bless him, his soul, and grant courage, and give all the courage and strength to his family. And I think we can make him live in the field of gastroenterology by emulating what he stood for.
Thank you very much, Dr. Sood, for those words. And with this, may I request all the people on the panel as well as the audience to observe 1 minute of silence and stand up wherever you are for 1 minute. Thank you. Thank you very much. I think with this we can move on to our masterclass, and thank you very much all the participants as well as all the members on the panel for this memoriam and condolence for Professor Rakesh Tandon. Well, today is the 23rd ISG Masterclass session, and it is a pleasure to welcome participants from all corners of India, from the neighboring countries, and even from some distant countries. It is fitting that the topic for today's ISG Masterclass is the diagnosis and management of biliary strictures, and there can be hardly any better method of better way of paying homage to Professor Tandon than to have a lecture on a subject that was very close to his heart, and also delivered by one of his own students who has also achieved great heights in the field of biliopancreatic diseases. Today, the speaker on this topic on the diagnosis and management of biliary strictures is someone who is one of the part of the endoscopy royalty of this country. Dr. Randhir Sood, a Padma Shri awardee, is the chairman and founder chairman of one of the most prestigious departments of gastroenterology in India at the Medanta Medicity in Gurgaon. He is also a past president of the SGI and has accolades too numerous to enumerate here. And he is also one of the star pupils of Professor Rakesh Tandon. Randhir is a good personal friend. I think we go back a long way. And in fact, I think from our MD days, when Randhir and Manu walked out of AB2 ward, that was when Shiva Prasad and I joined AB2 ward, probably replacing them in their on the vacant seats. He's blessed with a very sharp and an analytical mind and an equally facile tongue, so that he's never at a loss for words or solutions to problems. He's a master of repartee, and the twinkle in his eyes and a smile on his lips is never very far away. He also has a very focused and a very sorted out approach to problems, and I look forward to hearing his approach to the management of biliary strictures. Also, to moderate this session, we have another scion of Indians' first family in GI endoscopy, that is Dr. T. Sheshadri Chandrasekhar, who is also a Padma Shri awardee and a founder chairman of the Med India hospitals in Chennai. Everything that I've said of Randhir fits TSC also to a T. They are almost alter egos across the Vindhyas. He's famous for his humor and wit and wisecracks. And in fact, I've enjoyed quite a few quiz contests which he has moderated with his unique style. With these few words, I will request Professor Randhir Sood to share his screen and to deliver his talk today. Randhir.
Good afternoon. I think, as I told you, I will dedicate this lecture to the memory of Professor Rakesh Tandon. What we are going to talk today is diagnosis and management of biliary strictures. You can understand this is a very wide subject. So I have tried to cut out the details and give you the essence. So it is going to be a packaged juice rather than the whole fruit. So, when we talk of biliary strictures, we are talking of benign and malignant strictures. The benign strictures are predominantly created by us. They are iatrogenic, post-surgical, majority of them either following cholecystectomy, liver surgery, and today liver transplant. Or they are following inflammatory strictures, which account for the second largest number, which is like chronic pancreatitis, primary sclerosing cholangitis, and now autoimmune cholangiopathy. In India, we do get infective causes like tuberculosis or in HIV, and rarely you will get ischemic strictures following either interventional radiology procedures or because of PAN or the SLE. Most of them benign strictures can remain asymptomatic if they are partial, with just abnormalities of the liver functions being picked up with occasional cholestatic symptoms, or they can progress to jaundice with cholestasis. They can present first time as ascending cholangitis, or if they are largely asymptomatic, then secondary biliary cirrhosis could be the outcome. On the other hand, the malignant strictures are predominantly due to pancreatobiliary cancers, cancer of pancreas, carcinoma gallbladder, and cholangiocarcinoma being the three commonest, and of course the lymphomas and metastatic lymphadenopathy as the other causes of malignant biliary strictures. These are present initially with pruritus and abnormal LFTs, but progress to progressive cholestatic jaundice. And the key point is that we need an accurate diagnosis to guide us to appropriate management of this condition. So just to give you some points, post-cholecystectomy strictures account for 80% of the benign strictures, and 0.2 to 3% of the open lap choles, and double that number of laparoscopic cholecystectomies result in biliary strictures even today. And the difference is that the open cholecystic strictures tend to be more proximal in the common bile duct or distal common hepatic duct, while the lap cholecystrictures are higher up in the hilum. They are in the common hepatic duct and can extend into the hilum. Post liver transplant strictures, if they are due to dead donor liver transplant, they are like post open cholecystectomy strictures. But if they are due to live donor liver transplant, they are like hilar strictures. And 10 to 30% of the patients of liver transplant will develop strictures. 13 to 20% patients of chronic pancreatitis will present with biliary strictures and account for 10% of the total strictures due to in the benign biliary strictures. Primary sclerosing cholangitis is another infrequent but reasonably often seen entity. And we are increasingly diagnosing autoimmune cholangiopathy in elderly people as the cause of benign inflammatory strictures. The infrequent causes of benign strictures are enumerated here. They are more for the postgraduates to remember that TB, portal biliopathy, oriental cholangiohepatitis, HIV cholangiopathy, Crohn's disease. Even after a blunt abdominal trauma, we have 2 patients who had a car accident and subsequently resulted in distal biliary stricture. Ischemic strictures, as I told you, post-radiation strictures, and strictures following RFA and PDT, which are being applied intraductally these days for cholangiocarcinoma and pancreatic carcinoma, could be other causes. And rarely, Mersey syndrome and can result in stricture, and post-endoscopy sphincterotomy also causes stricture in some patients. And of course, as in many diseases, we don't know cause of everything we see, and there is a percentage of patients who have got undiagnosed cause of stricture. The carcinoma of the pancreas, the most common is the pancreatic ductal adenocarcinoma, but IPMN and neuroendocrine tumors are infrequent causes. In North, gallbladder cancer is the commonest cause of biliary strictures, malignant biliary strictures, while in South, cholangiocarcinoma is commoner cause, and 10% of the cholangiocarcinomas can be diffuse and not only hilar but can extend down into the distal CBD. It is often associated with primary sclerosing cholangitis, could be associated with ulcerative colitis or oriental cholangiohepatitis. Lymphomas and metastatic lymph node compression can cause high strictures like hilar strictures, and we should be looking for it. Metastasis from colon, lung, kidney, and pancreas are common areas which can cause obstructive jaundice due to lymph nodes, compressing the biliary system. Now, how do you diagnose these strictures? That's very important. And I tell you, we should never underestimate clinical evaluation in any disease entity, and same is true for diagnosing biliary strictures. You should take a detailed history and history of pancreatobiliary surgery in the past, a long history of pruritus or abnormal liver functions, evidence of chronic pancreatitis, evidence of inflammatory bowel disease, insignificant or no weight loss in a patient with the stricture, smooth hepatomegaly on examination with non-palpable gallbladder are all indicators of probability of benign stricture. On the other hand, the malignant stricture, the recent onset upper abdominal pain or diabetes, significant loss of appetite and weight, painless progressive cholestatic jaundice, a bilirubin of more than 20 milligrams per deciliter, hard nodular hepatomegaly and palpable gallbladder, and globular hard nodule in place of gallbladder are highly suggestive of malignant stricture. So these are absolutely free diagnostic tools for differentiating benign and malignant strictures, and very essential so that you can appropriately use more expensive diagnostic modalities. Now, we all use tumor markers a lot when we are faced with this situation. CA19-9 is the commonest use, and you must understand how good or bad it is. It can be elevated in cholangiocarcinoma, CA pancreas, CA gallbladder, and even hepatocellular carcinoma. However, it can also be elevated in benign diseases like cirrhosis liver, even gallstone disease and benign tumors, and particularly when there is presence of cholangitis due to any cause. And CA19-9 in a patient who has no cholangitis of more than 100 has a sensitivity of just about 60%. And for and negative predictive value is reasonable of 92% for benign biliary stricture. So if you have a CA19-9 which is more than 100 and patient is not having any cholangitis, then you can be, it will weigh strongly in favor of malignancy and go against benign stricture. If you take the cutoff at 300, the sensitivity drops down, but the specificity for malignancy becomes more, and that's why the higher the value of CA19-9, more relevant it is, provided there is no cholangitis. And if the value is more than 1000, there is it indicates inoperable cholangiocarcinoma with peritoneal metastasis. So it is again a low cost marker, but you should understand when to use it, and what are the caveats when you are interpreting the results of this. The elevated trypsinogen 2 is another marker which is elevated in cholangiocarcinomas, and it is particularly more valuable in patients of primary sclerosing cholangitis, which is the most difficult situation where we are where we face the difficult decisions of diagnosing whether it's a benign stricture or a cholangiocarcinoma superseding a patient of primary sclerosing cholangitis. And elevated trypsinogen 2 is found to be more sensitive than CA19-9 in these patients. CEA can also be elevated in about 70% of patients of CA pancreas. So if you have a combination of high CA19-9 and CEA, then it is also very suggestive of a malignant pancreatobiliary malignancies, particularly CA pancreas. Now, the ultrasound is the first non-invasive imaging which we all get done. We must know that it is a very good modality to tell you whether there is obstruction or not, but a poor modality when it comes to differentiating between benign and malignant cause of that obstruction, unless there is obvious metastasis, there is obvious gallbladder mass, then of course it's easy, and it also does not tell you the extent of the stricture. CT scan, on the other hand, is equally effective in telling you whether there is obstruction or not, and also is more accurate in differentiating between benign and malignant, because it can tell you whether there is a mass associated with it, whether there is a lymphadenopathy associated with it, and whether there is a irregular stricture or not. But extent of the stricture is not, it's only moderately accurate in telling you how long the stricture is and where all it is extending. MRCP is superior in telling us the extent of the stricture, but while it is also one of the best modalities to tell whether there is obstruction or not. And it's particularly of value in post-liver transplant patients, because there the ultrasound is not very good, particularly when we are dealing with live donor liver transplant situation. Then MRCP is the first investigation which we get to differentiate between the medical causes of abnormal liver functions post-transplant versus obstructive causes. The indicators of stricture, malignant stricture on imaging are mass if present. If there is a lymphadenopathy which is of significant size, any lymph node which is more than 1 centimeter will be suspicious of malignancy. The two precautions you have to take is that TB can present as lymphadenopathy and mass, and chronic pancreatitis can present as head mass, which is inflammatory. So not all masses on CT are malignant. We must always remember these two conditions. If there is chronic pancreatitis, a mass in the head of pancreas is not always malignant unless it has a very particular characteristics. Vascular encasement on CT scan or MRI is extremely important indicator that you are dealing with a malignant stricture. And lobar atrophy, which has happened on either left or right, is again a very strong indicator of malignant stricture. But prolonged cholestasis, prolonged obstruction to a ductal system, lobar system, can also result in some degree of lobar obstruction, lobar atrophy. So that should be interpreted in light of the clinical scenario. One word about hilar strictures. Hilar strictures are presumed to be malignant if there is no history of biliary or hepatic surgery in the past. So this dictum should hold. However, there are patients, or 15 to 20% patients, who will turn out to be benign, as borne out by these three studies where they saw, on resected specimens, they found benign etiology when they were resected for hepatic cholangiocarcinoma. The frequent malignant masquerades for hilar malignancies are isolated primary sclerosing cholangitis related stricture, that's the dominant hilar stricture, tubercular stricture, or autoimmune cholangiopathy, lymphomas, and a Mirzi syndrome or a stone stuck at the hilum. So we must remember these conditions when we are diagnosing hilar strictures, and not all hilar strictures are malignant, as was the dictum. So what is the next step in the diagnosis? Once we have done the cross-sectional imaging, we have fairly good idea, and we have diagnosed almost 80% of the cases by this. The EUS, but the step is to establish that diagnosis. And if you have a mass or the stricture is distal, then you proceed with endoscopic ultrasound and do an FNAC or FNAB as the situation demands. And if the stricture is in the hilum, or if there is no mass associated with it, or EUS is negative, Then you do ERCP and see the stricture morphology, as well as do the acquisition of the tissue by cytology or biopsies. See, this is the data of endoscopic ultrasound in biliary strictures without a mass. The 9 studies with nearly 550 patients, and without FNAC, the sensitivity was close to 80% and specificity 84% from malignant biliary strictures. However, in the meta-analysis of 284 patients, where EUS plus FNAC was done, it had a sensitivity of 84% and a specificity of 100%. So EUS is a very good, less invasive modality for diagnosing biliary strictures, particularly when you are suspecting malignancy as the is higher on your card. And the most important thing is its sensitivity in distal is almost 1.5 times higher than for the proximal strictures. So you can see this study that for hilar strictures, US IFNAC has 25% accuracy, while ERCP cytology and biopsy is 75%. For distal, it's the reverse. EUS is superior to ERCP. So always remember this, which modality to use and in which sequence, which is very important, because you have to ultimately, each time you do a procedure, patient is spending money and you are also increasing the morbidity. Now, how do you diagnose biliary stricture, biliary stricture on malignant biliary stricture on ERCP? Is the length of the stricture is more than 14 millimeters? If the stricture is irregular, if there is shouldering, that is eccentric shelf, if there is nodularity in the stricture or double duct sign, then it is suggestive of a malignant biliary stricture. And then the next step is to acquire tissue by either brushing, which is the commonest, or under fluoroscopic guidance aided by ERCP, you take intraductal biopsies and or FNA or a combination of these to increase your diagnostic yield, both sensitivity and specificity. Now, how accurate is the breast cytology and biopsy? I'll take you to these meta-analysis of, if you look at the breast cytology alone, the sensitivity is barely 41% and negative predictive value is 58%. And accuracy is just in 2/3 of the patients. So not very robust there. And this is another meta-analysis of 9 studies in 730 patients, 460 malignant and 270 benign. And you can see that breast cytology had sensitivity of 45%, biopsy had only 48%, and even if you combine both, it was reaching up to 60%. So you are leaving almost 35 to 40% patients where you are not certain what kind of stricture you're dealing with. And these are the clinical data that 20% of the biliary strictures are indeterminate, and repeated investigations are invasive, and this causes delay in implementation of appropriate care, causes cost escalation, it leads to physician and patient frustration, and is one of the causes of increasing litigation today, when you are unable to diagnose and you cannot take the surgical dictum that you operate if you're not certain, because patients ask you that they underwent so many investigations, why the diagnosis could not be established before the surgery was done. So we have to minimize the number of patients where you do the definitive treatment without a proper diagnosis. And almost 25% of the patients operated from malignant strictures turn out to be benign on retrospective analysis. So how do you improve the accuracy of diagnosis? You do better tissue analysis and or you take new information. Better tissue analysis, one of the cheap protocols was squash protocol, where you take one of the biopsies, squash it between 2 slides and send it to your cytopathologist who can see. And one study had shown it to be very increasing the yield by about 20%, but we did a thesis on it and we didn't find any improved yield by squash protocol. The very important thing is on-spot evaluation of the tissue, and this definitely gives you 2 information. That one is that whether your tissue you have acquired is sufficient. The second, it will also improve your diagnostic capability. And third is, of course, cytogenetic techniques, which are now readily available, where each cell you examine can give you added information whether it's malignant or not. In the new information, you can detail the morphology of the stricture by doing intraductal ultrasound, and or look inside with cholangioscopy, and under direct vision take tissue, do tissue acquisition to see whether it's malignant or benign. So let's look at these. If you do the on-spot, evaluation of the touch imprint from a biopsy, you can increase the accuracy by significantly. And this is a study from Vardarajalu. Though this study was on cholangioscopic biopsies, but the same can apply to radiology-guided biopsies taken on ERCP. And I think that this is one cheap way of increasing your yield. Now, a word about the the cytogenetic techniques. One is, of course, the image digital analysis, IDA, which is not digital image analysis, DIA, which is not being applied very routinely, but FISH is used in many centers now. And this is fluorescence in situ hybridization. What you are looking is polysomy, chromosomes with polysomy. And if you have more than 2 chromosomes, in more than 5 cells in the smear, then you have high chance of it being malignant. And particularly if the change is in particular locus of 9p21, then it increases your sensitivity even further. So if you have a cytogenetist in your hospital who's doing it for the lot of hospitals with the good oncology departments have now FISH available, and this is being done routinely. And I think we should start subjecting our breast cytology specimens for FISH, though it increases the cost, but this can increase the yield and prevent you from going ahead with more expensive investigative modalities. If it is of particular importance in patients of primary sclerosing cholangitis with with cholangiocarcinoma, where 70% positivity is found on FISH. So this is a difficult situation where FISH can be particularly good in yield. The intraductal ultrasound, though, has very high specificity and sensitivity, and it does increase the tissue acquisition. It does increase the yield when combined with ERCP. However, the problem is that this is not being done very frequently, and it is an expensive investigation because the equipment is still very fragile, and only limited centers do it. It is not a common tool for differentiating benign and malignant biliary strictures. What is the new buzzword is cholangioscopy, that which has made it possible for you to look inside the biliary tract and take additional information, visual information, as well as give you direct biopsy opportunity. And this is something which has increased our yield of strictures in differentiating benign and malignant strictures. You can see the video on the left, which is playing, which shows you very clearly concentric rings, which are fibrotic, and there's no question it is a benign stricture. Just a look at it will tell you. The other hand, you can see new vessels formation on the stricture, and this is very clearly malignant. You don't even have to take a biopsy. This is 100% accurate if you find these findings. Or this type of vision was only available with video cholangioscope, which had no biopsy facility in the earlier. But now we have a very high probability of doing visualization with the DigiSpy, through which we can also take biopsies. You can see the new vascularization and nodularity of a stricture. This is one of our patients. And you can see that you can easily, on visual impression, this leaves no doubt that this is a malignant stricture. And in addition, you can also take biopsies to further increase the specificity. So what are the findings on cholangioscopy which favors malignant strictures? Is that tumor vessels, large tortuous vessels, if present in 2/3 of the patients, and this they are never present in benign strictures. And positive predictive value is 100% for malignancy, and biopsy plus vessel has a sensitivity of close to 90% and specificity of 100%. A nodular infiltrative stricture is highly suggestive of malignancy. If there's oozing of blood on touch, particularly in patients which has not been stented earlier, is again very highly suggestive of malignancy. And if it is a benign stricture, concentric rings and short papilliform or smooth surface favors a benign stricture. And this is the data of digital spyglass in indeterminate biliary stricture. You can see that even visual impression has a very high sensitivity and specificity. And when combined with histology, though the positivity of biopsy is not so high, it is in the range of 70%, but the specificity goes to 100%. Now, the question is, we know that cholangioscopy can be done. We know the EUS can be done. We have to, utilize these resources in a logical manner. And this is one study on 40 patients of suspected malignant biliary strictures, and ERCP cytology was negative. So first EUS was done, which picked up a stricture suggestive of malignancy, but EUS was, the FNA was feasible only in 3/4 of the patients, and cytology was positive in 60%. Of these patients, which was 13, which were negative on EUS FNA, spyglass was done, and 88% were positive. So overall, you could, if you use EUS first and then cholangioscopy, you could easily diagnose 94% of the patients without duplicating the resources. However, 2.5% patients did develop cholangitis, and particularly in the hilar blocks. One modality which I'll just give you a glimpse of is, the confocal laser and endomicroscopy, which is in evolution. We have still not reached a stage where we can do in vivo, classification of benign and malignant. And this doesn't have an incremental value in increasing the yield for malignant and benign strictures. But I think we need to characterize the findings in greater detail before we can apply it clinically. Biliobiomarkers are a very interesting development because there are certain markers which are enumerated here: carcinoembryonic adhesion molecule, NEGAL, MCM, VEGF, IGF, HSP. These get increased in malignant strictures, and these can be analyzed from bile. So you do not have to go do sophisticated tests. You can take a bile sample. If these markers are high, then this will suggest malignancy. Though we need to, there are earlier initial studies which show that they have got sensitivity and specificity in the range of 65 to 85%. But I think we need authentication of these reports before we apply it in clinical practice. So the first part of my presentation, I like to summarize that clinical evaluation and cross-sectional imaging can diagnose most of the most of the strictures, almost 80%. EUS and ERCP are next step in establishing the nature of the biliary strictures. Accurate diagnosis of indeterminate biliary strictures remains a challenge, and on-site tissue evaluation, cytogenetic techniques like FISH can improve the sensitivity of the conventional techniques. For undiagnosed strictures, cholangioscopic visualization and biopsy will increase the yield, and intraductal endomicroscopy is still in evolution and may actually give you in vivo microscopy. And biomarkers, we are waiting for their status to be established. Thank you very much for patient listening. I'll be presenting one slide of questions to the attendees so that just to see whether they have been listening to the talk carefully or not. So this is a clinical case scenario. 62 years patient with painless progressive cholestatic jaundice, a diabetic and hypothyroid on treatment for more than 5 years. CT scan shows thickened common hepatic duct and proximal CBD, no mass. MRCP shows a smooth stricture with no mass at the hilum. CA19-9 is just 25. What are the tests you will not do to establish the cause of stricture? So these are the tests: EUS, ERCP with breast cytology, cholangioscopy and with biopsy, IgG4 levels. So I'll leave you with that, and I'll hand over the space to Professor Vivek.
Yeah, I think while the answers are coming in, Dr. Chandrasekhar, I think maybe you start with questions, please.
And at the outset, I would like to thank ISG for giving the honor to moderate. And you know that biliary stricture is a very challenging, not only in diagnosis and management. And Dr. Randir Sood has done a very fantastic job in enumerating what are the diagnostic modalities available. However, despite all these things, there are situations where we won't be able to diagnose. So how to proceed further? And meanwhile, I got a lot of questions on diagnosis management. I will take a few questions which been posed to Dr. Randir. Dr. Rajendra Patel from Mangalore is asking what is the role of newer tumor markers like TTR, IL-6 and MMP7 in biliary stricture evaluation?
I think I just touched upon the biomarkers in evaluation of the biliary strictures. As I told you, they are being studied, and I don't think that they are prime time yet, and we cannot rely upon them at present. And I think we should restrict them to the research laboratories till more data is available, because we don't know whether NGAL will be the right thing, or it will be mTOR, or it will be MM. RNA. So we still are in evolution.
So it's under evaluation.
Yeah.
A question from Dr. Anand Chennai. While US examination of biliary stricture, indwelling biliary stent hinder the accurate analysis of the stricture?
Well, it does, because it does have artifacts generated. That's why it is a practice in most of the centers that we take out the stent first, if it's a plastic stent, and then do the AUS. With a metal stent, it becomes doubly difficult. But if there is a mass associated, or if there are lymph nodes associated, you have an opportunity to sample them.
I think I agree with you, Randir. Actually, before putting an indwelling stent, we try to evaluate as much as possible the US. Where mass lesion and lymph node, even with the stent, is not a problem. But you want to analyze the intraductal element, then the stent can be hindrance.
One point here, I think the message should go very clear. Think and then stent. Don't stent and then think.
Yeah, that is fine. Particularly, it is a operable case where you think early malignancy, you should not miss out the opportunity of being operated. The other question is, the more challenging is proximal biliary stricture or distal biliary stricture?
Most challenging is very distal, but still EUS can differentiate that, and you can still do one very distal. You can do a papillotomy and take direct biopsies from that. But proximal stricture, which is hilar, the problem is that if the EUS has not shown anything and the EUS could not take FNA, then you will have to do a cholangioscopy.
I agree with you.
The problem comes in that after cholangioscopy, you have about 10% chance of introducing infection. So you will, after doing your biopsies, after doing your visual analysis, you will have to do temporary stenting with a plastic stent so that you avoid any cholangitis, particularly if you think that the bile is not, the contrast is not draining very well, or you use minimum irrigation fluid to increase the intraductal pressure. And another tip is that do a wide papillotomy so that when you are irrigating, even with a syringe, the fluid keeps on moving out and you only clear the field and you don't increase the intraductal pressure to contaminate the intrahepatic ducts.
The question from Pradeep Nigam from Reva. What is can US replace MRCP in evaluating biliary stricture? If the US expertise is available.
No, I don't think it can, because EUS can only tell you about the proximal ducts, but MRCP can tell you the entire ductal system. EUS cannot tell you about the PSC if it is restricted to certain areas, while the MRCP can tell you. So it cannot replace. And never think of what you have is the best modality. Think of its place in the proper algorithm of a disease.
So both will be complementary.
Yeah.
It can't be replaced. We have a special situation, lower biliary stricture, very lower. No mass available, no mass. Spyglass is not possible. US has got very little to do. And the CA99 is plus minus. So how will you proceed?
You see, in this situation, I told you there are two ways. One is that you use your US and take a 25 gauge needle and do the aspiration with that. Or you do a papillotomy if it is a very distal stricture, and you take biopsies as well as do brushings of the distal stricture, because this is amenable to direct biopsy if it is very distal and almost reaching up to the ampullary area.
I think it's a very good message what Randir is pointing out. The message is when a very lowermost stricture, better to do a papillotomy and take biopsy instead of just taking a biopsy or taking a brush cytology. Dr. Sood, do you ever have to undergo surgery? I mean, send a patient for surgery if the lowermost CBD stricture anywhere it is, nothing is possible, diagnostic measures.
We do.
What is your take?
I think it is the situation which will happen in about 5% of the patients, where we'll have to tell, looking at the age of the patient, looking at the, the risk profile, we will decide whether the probability of it being malignant is high, then we will subject these patients to surgery. The other protocol which we follow is we put a fully covered self-expanding metal stent in this situation, observe the patient again after a period of time, whether it is progressing or not. And if it is not progressive, then we know there is a benign stricture. Otherwise, if we find there is evidence of progression, then we get a Whipple's done.
So can we go to talk and then we come back to questions?
Only one last question.
Yes.
There is the question from Rajendra Patel from Mangalore. What is the value of Kurvoiser law in this era of modern imaging?
Oh, it is still holds true. I don't think any of the clinical science has gone away. All these signs are to judiciously use your investigative armamentarium and not definitely diagnostic. Earlier, we used to put too much of weight in diagnosis. Today, we put the weight on the way you are going to take ahead.
I think we're winding up the first part of the session. The best message is when you have a lower CBD stricture, nothing is possible. Do papillotomy and type biopsy. This is the best message. And I'll hand over the mic to Vivek and Govind.
Sir, Dr. Sood, sir, we couldn't project your question, so we don't have answer from our audience.
Okay.
So probably we'll skip the audience poll this time.
Sure. So shall I share the screen now?
Yes, please go ahead. Continue the talk.
Let me get it back. So, are the slides visible now?
Yes, sir. Yes, sir.
Okay. So now we come to the second phase, which is managing the biliary strictures. Once we have diagnosed, then you know that how you're going to manage it. You have decided by now that the patient has benign stricture or a malignant stricture. The most important thing at present is to that you have to decide whether you're if it is benign biliary strictures, then you have to decide on the etiology, because there are different diseases you're dealing with. It would be, as I told you, post-operative, post-cholecystectomy, liver transplant, chronic pancreatitis, IgG4, or PSC. So there is going to be a different etiology, but the management principles may remain same with many of these. And main emphasis will be on the commonest causes of these strictures. So what is the principle? Principle is that we want to provide a long-term bile flow. However, earlier the surgery was considered to be the gold standard, and because it had a reasonably high success rate, but it had a morbidity which was significant. It had a recurrence of almost 20%, and in about 20% of the patients, you needed to redo the surgery for re-establishing the biliary continuity. And for providing this long-term bile flow, the surgeon creates a wide stoma. That's the argument, surgical argument, that because we do give a stoma of 2.5 centimeters, where the can endoscopists do that. But my question always remains that nature gave you a bile duct which is 4 to 6 millimeters. It never gave you 2.5 centimeter bile duct. So all that you need is a reasonable flow of bile through a passage which is barely 6 millimeters. And so what happens to the surgical stoma? That almost 2/3 of the time, the size of the stoma keeps on narrowing, and it ultimately shrinks by almost 2/3. On the other hand, endoscopically, we can create a passage, but we have to have strategy to maintain that passage so that long-term the patency remains. So ultimate goal of treating a benign stricture is long-term bile flow, how we achieve it. and now we can achieve it as effectively endoscopically as with surgery, with much less morbidity and mortality. And today, the endoscopy is the first choice in treating patients of benign biliary strictures. The endoscopic management protocol is very clearly defined now. You do a cholangiogram, you define the stricture, you put in a guide wire across, you dilate it, put in, the principle of balloon dilatation is you do not measure the proximal CBD, you measure the distal CBD and dilate 1 to 2 millimeter larger than the distal CBD, downstream duct. And as many stents as possible you should place in the first go itself. And every 3 to 4 months, change these stents and take the size a little bit higher to as many stents which are possible to introduce. And obviously, you have to do a wide papillotomy before it, so that inward stent migration doesn't happen, and you can easily place stents. And you have to repeat this 3 or 4 times, depending upon the interval, for a year, and that will give you the best long-lasting results. Here are certain examples. A biliary stricture, short, after open cholecystectomy, you do a balloon dilatation, put in multiple stents, and at the end of year, you can see a remodeled stricture. Similarly, after post-flap chole, the strictures are higher, and you can see it is going to the hilum, and it looks very difficult to treat. But if you do it properly, you dilate the stricture, you put in stents in left and right ducts, and you can see at the end of 1 year, you have this anatomy, which is as good as the anatomy which the patient had before the injury happened. So the morphologically, it can give you excellent results. The only thing is that all patients are not amenable to endoscopic treatment. Those with complete transection or ligation of the bile duct cannot be treated. So you must do a occlusion cholangiogram in a tight stricture, establish that no dye is going in, and if it is a fresh stricture, you can try a guide wire. Otherwise, it's a long stricture, you do not need to try a guide wire. If no dye is going, it goes to the surgeons, and you can't do much endoscopically. Though there are other techniques, but I don't think it is worth wasting patients' money and time on very difficult techniques to establish a continuity unless comorbidities dictate so. So let's look at the long-term outcomes of lap cholecystectomy strictures endoscopically treated. There are 4 studies I'm giving you with long-term follow-ups, and you can see that the success rates are 80 to 90%. And this is Costa Mania's study, has the longest follow-up of nearly 14 years. And you can see these were the patients from this study in 2001. And of these 45 patients, 7 patients had died within 7 years of other causes without any biliary symptoms. And 35 patients could be followed up. And of these, 80% were free of any biliary symptoms at even 14 years. 7 patients had the symptoms. Of these, 4 had stricture and which needed endotherapy again. 3 had stones which could be removed. So only 11.4% has recurrence, and 80% patients had long-term benefit after endotherapy. Now, coming to the post-liver transplant strictures, a dead donor liver transplant, it is a large duct to large duct anastomosis in the mid CBD. It is treated exactly like post-cholecystectomy strictures, and success rates are also similar. Restenosis is nearly the same. It is managed endoscopically, and surgery is only done for recalcitrated strictures. But when it comes to the live donor liver transplant and anastomotic strictures, the things are different, because it's a small duct, a lobar ductal system, anastomosed to the recipient duct, which is normal, and there's a mismatch of the ductal anatomy. This is done at the hilum, and these strictures are normally complex and peripherally located, multiple small caliber ducts. There could be more than one anastomosis. It could be anastomosed one duct, one segmental duct could be anastomosed to the the cystic duct. So they are more difficult to treat, and that's why endotherapy is less rewarding than the DDLT, and it is in the range of 60% to 75%, not in the 90s. And very tight stricture, if you find on post transplant, this is the commonest cause of failure. The one principle in dealing with live donor liver transplant stricture is that you must have an MRCP beforehand and look at all the segmental ducts very carefully, talk to your liver transplant surgeon about the nature of the anastomosis, and then access all segments. You see, here we have put in 3 guide wires in one go, and so that we have accessed all the segments, and then we put 3 7 French stents in all these segments so that each segment got drained, and subsequently we will, when we are putting 7 French stents in proximal strictures, we try to exchange it sooner, possibly at 2 months, and because they have a higher risk of cholangitis, particularly after transplant. So after we have upgraded to 10 French, then we go to 3 monthly exchange. Then another contentious issue is the biliary strictures with chronic pancreatitis, because it's an inflammatory stricture. The problem is not with the bile duct, problem is in the surrounding tissue, which is chronically inflamed, and the inflammation may be still ongoing, and also there is calcification. So these strictures tend to be difficult to treat. This is a very good snapshot of the outcomes, and you can see that till we were using only single stent for treatment, our results were in the range of 10% to 40%, less than 40% success rate. But when we started using the same principles, which we are used for benign biliary strictures elsewhere, of putting in multiple plastic stents, our results started improving. I'll come to that later when we talk of fully expanding, covered self-expanding metal stents. Another difficult area is biliary strictures in primary sclerosing cholangitis. We must remember you can never correct entire anatomy of the biliary system endoscopically. You only aim at dominant strictures. What are the dominant strictures? Strictures in the distal CVD or strictures in the hilum, in the first level ducts. You do not go to second level ducts, you don't go to tertiary level ducts, you will end up infecting these patients rather than benefiting the patient. 35% patients will develop dominant strictures over 8 years, and half of the patients will develop them over 15 years. So you should, if you have a patient of primary sclerosing cholangitis, you should always be putting these patients on surveillance. The difference in the treatment of PSC related strictures and the other benign strictures is that in PSC related strictures, we never put in a stent. This is one condition where you do only balloon dilatation, and this is superior to stenting because the infection rates in PSC after stenting are much higher. So always remember this dictum. So the other thing which has happened in the management of the biliary strictures is the coming in of fully covered removable self-expanding metal stents, because this gave us an opportunity to put in a stent in one go, and it was very easy technically to put in these stents, and you can achieve a diameter of the stricture of 1 centimeter and leave the stent in for a defined period and then remove it, and you have maintained the dilatation right from day 1 at 1 centimeter instead of incremental stenting in plastic stents. So we expected it to be working better. Now, I'll give you where do we stand with the fully covered metal stents versus multiple plastic stents. What should be our protocol? This is one large meta-analysis of nearly 1,300 patients of 22 studies, of which there were 4 randomized controlled trials of 213 patients, which compared fully covered self-expanding metal stents with multiple plastic stents and for stricture resolution. For benign strictures, stricture resolution, stricture recurrence, and adverse events were same whether you use plastic stents or fully covered self-expanding stents. But where do the fully covered self-expanding metal stents gain? You needed fewer interventions. So patient didn't have to come every 3 or 4 months. You could put in a fully covered metal stent once and remove them at a defined interval, and the job was done. And the cost, because of this decreased number of procedures with fully covered self-expanding metal stents, actually is half. Even this is true for India, because the cost of ERCP in India is also not low, and the complications associated with the ERCP are also high. So I think fully covered metals, self-expanding metal stents are a way to go, provided there is technical possibility of putting these stents. How long do you put in these stents? For multiple plastic stents, it is defined that you put in for 1 year, remove them every 3 to 4 months, and till you achieve the maximum stent size. And at 1 year, you evaluate for the remodeling of the stricture, and you do not proceed further if the stricture has remodeled. In the fully covered stent, the ideal time is still not defined. However, there is one study which has shown that 6 months indwelling fully covered self-expanding metal stent is superior to 3 months indwelling fully covered stent. Sphincterotomy, I must caution, is a must before putting in a fully covered metal stent, because there is one study which showed that there is a significant risk of pancreatitis if you do not do sphincterotomy. So ESG guidelines published in 2018 again say that temporary insertion of multiple plastic stents or fully covered self-expanding metal stents can be used as treatment for biliary benign strictures. So you can choose. The choice depends upon the cause, the location of the stricture, because you cannot use it very high up in the hilum, and the CVD size and the experience of the operator. Now coming to same thing situation in chronic pancreatitis, whether we should be using multiple plastic stents or metal stents. Both the multiple plastic stents and fully covered metal stents have been used. Stricture resolution rate in 470 cases was 61 to 85% with the self-expanding metal stents, and this is one randomized controlled trials comparing the two, and similar resolution rate with multiple plastic stents versus fully covered self-expanding metal stent. Similar treatment related morbidity. Duration of stenting was 6 months in this trial for both, which was surprising. And the problem in this trial was that initial part, some cases were done with partially covered self-expanding metal stents, and that's why they had difficulty in removing 4 out of 28 covered stents in this group. So so far, I don't think that you have a superiority of fully covered self-expanding metal stents in treating pancreatic ductal stricture in the strictures, biliary strictures in chronic pancreatitis. However, if the patient is coming from far off and patient doesn't want repeated procedures, I think that's an option. So coming to the, let's shift gears and come to the treatment of malignant strictures. Here again, I want that the most important message of this talk is establish surgical resectability and potential for care before you do any invasive procedure in this patient, or do that procedure with this intent first. So please do this, because we see innumerable time that in our desire to stent a patient, we assume patient to be inoperable and then do something and then we regret later. So preoperative drainage is done only if it is indicated. There are very defined indications, and I'm not going to go into details. Palliative drainage only if patient is unresected. And you can use plastic stents, uncovered stents, or fully covered or partially covered self-expanding stents. I'll be giving you the data of whether you should be using plastic stent or metal stent in the palliation of malignant biliary strictures. This is a meta-analysis of 20 RCTs of 1,713 patients of comparing plastic versus SEMS. Here, the self-expanding metal stents have clear superiority, no questions. Longer stent patency, 6 months symptom-free survival was better with SEMS, lower late complication rate. However, the 30-day overall mortality was same, though there was survival benefit with the partially covered SEMS, uncovered SEMS, but not with covered SEMS. So there is some survival benefit too with the uncovered SEMS in malignant strictures. There is another meta-analysis of 19 studies of nearly 2,000 patients, and half of patients had SEMS and plastic stents. Again, longer patency with SEMS. Therapeutic failure was higher with plastic stents. Cholangitis was higher with plastic stents. Fewer interventions required with self-expanding metal stents, and 30-day mortality remained same with both. So today we have 5 meta-analyses comparing plastic stents with SEMS in malignant biliary bile duct obstruction. And the take-home message is less stent blockage and cholangitis with SEMS, less interventions required with SEMS, longer patient survival possibly, and cost-wise, SEMS are at no disadvantage. And even in patients with less than 3 months survival, I think SEMS have advantage over plastic stents, and health-related quality of life index is better with SEMS. So today, I think for malignant biliary obstruction palliation, plastic stents have only one role, that if you are trying to establish the diagnosis and you're not certain, then you temporarily put in a plastic stent. Otherwise, for palliation, you should always use the self-expanding metal stent. Now the question is, shall we be using uncovered or covered? Let me give you the data. 7 meta-analyses compared partially covered or fully covered metal SEMS with uncovered SEMs. And there was no evidence of superiority in stent patency, complications, stent dysfunction, or survival. So covering on the stent does not benefit you. Covered SEMs have definitely lower ingrowth but higher overgrowth and stent migration rate and sludge formation. In fact, 4 meta-analyses looked at incidence of cholecystitis. There's no increased incidence of cholecystitis with covered SEMs. So that is not the risk, but there is no advantage. So just to summarize, benign disease, indeterminate stricture, you should put in a plastic stent or a fully covered stent which can be removed. Palliation of malignancy, definite malignancy, SEMs. Preoperative drainage, you can use plastic or SEMs, which depending on the situation. Now, I will spend 2 minutes on hilar malignant biliary obstructions because this is a special area. ERCP in malignant hilar strictures is a high-risk procedure. We must understand not everybody should attempt hilar strictures with increased morbidity and decreased survival in failed drainage. If you fail in distal stricture, you can come out with just putting in a plastic stent and you will not harm the patient. You will only have to send it for a proper procedure elsewhere. But if you fail in malignant hilar stricture, you will harm the patient definitely. A meta-analysis of 13 studies in more than 60,000 patients have clearly shown that higher clinical success and lower adverse events in high volume endoscopies. So ASG grades ERCP in hilar blocks at level 3 difficulty, and it is best done in endoscopists by endoscopists in high volume centers. And again, resectability and diagnosis of malignancy must be confirmed before we intervene. Again, some data about SEMs or plastic stents in hilar. Again, there's no question. If for hilar, the superiority of SEMs is even higher, and 6-month patency is almost 4 times. The 50% patency rate is 3 times. Re-intervention is 3 times with plastic stents. Overall cost of treatment is much less with SEMs. So no difference in overall survival because that is disease determined. So I think for hilar blocks, there's no second thought. And they are superior to plastic stents. And in fact, both the consensus guidelines of Asia Pacific as well as ESG totally endorse that. Whether you should be putting in single stent or bilateral stent in bismuth 2 and higher malignant hilar strictures, there are 3 meta-analyses, and one analysis showed that unilateral is higher technical success and clinical success, complication and 30-day mortality was same. However, the latest multicentric randomized control trial shows that SEMs in bismuth 2 and higher malignant hilar blocks in 133 patients, there was longer patency with bilateral drainage. There was need for fewer re-interventions, and particularly today you are subjecting your patients to adjuvant chemo radiation. So bilateral stenting wherever possible is the goal, so that the patient does not develop cholangitis during adjuvant therapy, and drainage of more than 50% liver volume is ideal, and 30% should be minimal for palliation. So whether we should be using ERCP or PTBD, there is for hilar, there's 1 meta-analysis in and 2 randomized controlled trials, and there is PTBD was more often successful than ERCP in complex grade 3 or 4 bismuth blocks, and but adverse events and 30-day mortality remains same, and quality of life improves with both similarly. So the choice should be with the expertise of the unit as well as choice of the patient. And I think in type 4 or type 3, we should seriously consider the access through PTBD if there is a chance that you may not be able to access all the ductal system. One word about contrast-free stenting. This is one area which is very close to us because we started this, the air cholangiography and contrastless stent placement in hilar blocks, and is iodine contrast-free stent placement. 2 randomized controlled trials and 2 retrospective studies show low risk of cholangitis if air or carbon dioxide is used. So there is definite virtue in not putting in contrast in bismuth 2 and higher blocks, so that you can drain all the segments and not contaminate the undrained segments. What happens when ERCP fails? The conventional approach was PTBD, as I told you earlier. It has very high success rate, but today we have EUS guided biliary drainage as an evolving option. And the efficacy and safety of EOS guided biliary drainage in comparison to PTBD was studied in this study, which is here, 9 studies, this meta-analysis, 9 studies, nearly 500 patients, no difference in EOS BD versus PTBD in technical success. And EOS BD had better clinical success, lower adverse events, lower reinterventions, similar length of stay, and more cost effective. So if you have expertise in USBD, then maybe this is the way forward if you fail in cannulating with the conventional ERCP. A word about tumor ablative strategy. So far, we have already talked about the biliary drainage, but today we have evolution of certain biliary ablative strategies which can be delivered through the endoscope, like photodynamic therapy and radiofrequency ablation, and percutaneously like brachytherapy. And just to give you a snapshot, this is one study of success of photodynamic therapy in palliating patients with non-resectable cholangiocarcinoma, a systemic review and meta-analysis published in 2017. It gave, if you do photodynamic therapy, there's better biliary drainage, better performance drainage of the patient, and though there is cholangitis in and reversible photosensitivity in 20% of the patient. And also not only better biliary drainage, there is also survival benefit if you do PDT in these patients. However, the equipment is expensive, and photosensitivity is one of the issues when applied in a place like India, but no new photophores are being developed which have got much less potential for photosensitivity. And I think with the improvement in the equipment, this may become part of the standard of care for patients with cholangiocarcinoma and gallbladder. The word about radiofrequency ablation and with biliary stent placement, again, you can see that RFA group had longer stent patency, and even survival benefit was shown in this meta-analysis. So there is virtue in having RFA with you and doing RFA in intraductal malignancies before putting in a uncovered stent, so that you can do tumor ablation and have longer stent patency and longer patient survival. So this is the end of my talk, and to summarize, establish the diagnosis and resectability in malignant biliary strictures. This is the foremost and the most important message I want you to carry. Never do any intervention without establishing this. Distal and bismuth 1 blocks are best treated with single SEMs, and covered SEMs have no advantage over uncovered SEMs. Bilateral SEMs, if technically feasible, in bismuth 2 and higher strictures. And MRCP roadmap is a must for higher grade Hyler strictures. Decrease cholangitis risk with air cholangiography. And if you're familiar with the technique, I think this is worth it. PTBD or USBD may be suitable alternatives if ERCP fails. Tumor ablative strategies may become standard of adjuvant treatment. Thank you very much. I'll hand it over to Dr. Vivek and Dr. Makharia.
Well, thank you very much, Dr. Sood. Perhaps you could stop sharing your screen now. Yes, thank you. I think it's been a wonderful exposition of where we stand on the diagnostics and the management of strictures. A vast area covered very economically and efficiently in the last 45 to 50 minutes. Well, I think we are already about 1:20, and probably we'll have another about 10-15 minutes to take up some of the numerous questions that have come your way, and to set the ball rolling, Randhir. I think I'll start first with some of the diagnostic part of your talk. So Dr. Suprabhat Giri from Mumbai wants to know how many times would you do brush cytology in a stricture before you finally think that there is little point and it is accepted to be a non-malignant stricture?
Well, as I told you, there's no such protocol that you repeat the stricture, the brush cytology. If you can have 3 or 4 passes when you're doing it, and you should combine it with a biopsy, fluoroscopically guided. And the easy technique is to put in a pediatric biopsy forceps through the ERCP scope, and guide it to the strictured area and take biopsies from the wall. And if these tissues are negative, it is cost ineffective to keep repeating an ERCP again. You should go with the next step. That will be cholangioscopy and direct visualization as well as the biopsy.
Right. So brush cytology just once, because after you've brushed it a couple of times, it starts oozing and there is a lot of bleeding. And then you're talking about a biopsy through the scope.
Yeah, you can combine brush and biopsy both. in the same sitting.
Right. Okay. Dr. Bal Murli from Salem wants to know about the role of bile aspiration and cytology in diagnosis of malignant biliary strictures. And that's also a question from a couple of others. Dr. Kailash from Mumbai wants to know, is there any place for stent impressions? You placed a plastic stent, and when you're removing it, taking impressions from that, does it help in diagnosing malignancy?
Well, we do bile cytology in our unit. It's we found that it has a very marginal incremental role to brush cytology and biopsy. As far as the stent, we did flushing of the stents and everything. Again, doesn't help much. I think it's worth spending more time in taking proper brush cytology and biopsy rather than these techniques which are unreliable, not substantiated.
Randir,
Right.
I agree with you because a lot of literature available now. Bile cytology has not improved the diagnostic yield nor the stent impression. I don't think we should waste time in that. We should go ahead with the higher level of the investigative
Next step,
modality.
that is cholangioscopy and biopsy.
Yeah.
That might be an improvement. Okay, so now regarding, you mentioned the problems of PSC, and that the PSC strictures should be managed only with dilatation and without stenting as far as possible. So we have a case that Dr. Rajendra from Mangalore has suggested, has proposed that there is a elderly male with chronic liver disease. MELD is 22, is decompensated and has a tight mid bile duct stricture. The background is of with associated IBD, and the suspicion of PSC is strong. And the CA99 is also mentioned as 373. So how would you approach such a stricture?
I will not approach the stricture. I'll approach the patient and send toward liver transplant.
Right.
So the thing is that I told that think before you do. You think of the patient and disease in totality. This is here you don't look at the eye of the fish like Arjuna. You look at the total problem.
So you do not need to bother about tissue diagnosis here. The whole picture is suggestive enough to proceed to the next step or to a different line of management. Yeah, right. What is your approach to asymptomatic biliary strictures? Do they require treatment? Is Dr. Raja Yogesh from Chennai and Dr. Anand from Chennai want to know about that.
I think this is a very important question, particularly when it is associated with chronic pancreatitis. That there will be morphological stricture, but it is asymptomatic. But if the alkaline phosphatase is more than 2 times normal, 3 months apart, and then you should be thinking of treating it, because these patients have a higher risk of developing secondary biliary cirrhosis.
Exactly.
So you do 2 alkaline phosphatase and values 3 months apart.
So this was Dr. Yogesh's other question, that are there any predictors for development of SBC in asymptomatic? You mentioned about alkaline phosphatase elevation persisting. Other than that, how about looking at liver stiffness or other ways for predicting the risk of SBC?
See, the risk, the stiffness, once it has increased, secondary biliary cirrhosis is already established. We are talking of before it establishes.
Right.
And so that's where the difference is. Because if it's alcoholic pancreatitis, there could be alcoholic liver disease associated with it. We have to understand.
Okay.
You have a very interesting question. What is your treatment protocol in portal biliopathy-related strictures with the non-shuntable veins? Is from Amit Agarwal from Nagpur.
Shuntable portal veins.
Non-shuntable veins
you
have.
Is not an option. Then the protocol is very clear. You have to do it endoscopically. And earlier we were scared of treating patients of portal biliopathy. Now we have seen that if you are careful, there could be organic stricture, that is the real stricture, or there could be just a morphological stricture because of the veins, intraductal veins. And if it is a stricture, we put in a multiple plastic stents. One of the things we do, we have no evidence that it really helps, is cut the proximal flap so that while withdrawing it, it doesn't cause injury. We also put these patients, give these patients, if they are not having a cardiac issue, 2 milligrams of IV terlipressin on the table, so the portal pressure is low. I don't know how much it is worth in compartmental portal hypertension. Again, these two things are purely impressionistic and individual choice, not based on any data or evidence. So we treat them with we are not very aggressive in the beginning. If there are associated stones, we remove them, and we try to dilate very gently. We do not do large dilatation in these patients. Now there is evolving role of putting in a fully covered metal stent in these patients, which has a double benefit. We have used it for esophagus to obliterate the varices. I think that if you put in a fully covered metal stent in bile duct for obliterating the stricture, you also obliterate the veins because you keep them compressed, they become thrombosed. So subsequent stricture resolution as well as secondary stone formation can be tackled very easily in these patients. So we are now going more for fully covered metal stent use in these patients.
Well, I mean, that's a problem there, and here is that it's not going to be of much use if there is hilar involvement.
Oh yes, in hilar,
the
hilar, if
you have lower end,
you have to use plastic stents or coffee stent if you have a margin there.
Coffee stent, if there is a margin. But Dr. Kailash Kole from Mumbai wanted to know, you've mentioned stent changes in people with benign biliary strictures. So at every 3 monthly intervals is the general protocol. But if the patient is asymptomatic and there appears to be pneumobilia, should you go ahead, or you can actually not stick to this protocol?
3 to 4 months, I told. This is depending upon your risk perception of the patient, whether the patient can come easily or not. There is no hard and fast rule. The question is, patient is today asymptomatic. 10 days later, patient comes to you with acute cholangitis, suppurative cholangitis. What do? You will have a problem at hand. So this is unpredictable. I think that is the reason where you can put in a fully covered metal stent. It has advantage because you have a shortened treatment period and you can treat these patients with fully covered stents. Yes, hilar, once they are lap chole associated strictures, you will still have to use plastic stents in most of the situations.
Randeep, I have a question from Dr. Abhiman Pawar from Sangli. While you are evaluating proximal biliary stricture with a spyglass, how much care will it take you to avoid cholangitis, or when do you avoid spy scopes?
Well, I'll first thing the second part first. I'll avoid spy scope if I'm not getting a good access into the biliary system. If the stricture is very distal, spy scope has no role. If the in hilar strictures, we will always try to prevent cholangitis. You see, while you're doing stone lithotripsy, you're very liberal with irrigation. You put your foot on the pump and you keep on injecting water, you're not bothered. While you're doing it for the stricture, you use a syringe for irrigation, and our protocol is we inject and suck, so that we keep on decreasing the intraductal pressure. And as I told you, we will do a reasonably wide papillotomy or do a balloon dilatation so that the downward flow of the fluid is good, so that there's no built up of the intraductal pressure. And as I told you, if we fear that there is a tight stricture in the hilum which we have brushed and which we have crossed, and then we are or taken biopsies from, then we are going to put in a plastic stent till we get the the histology. Or if we have a very definitive morphological evidence like neovessels and nodularity, then you can decide to put in even a metal stent in that situation.
Now, his question is, can you just visualize the lesion without injecting water?
I told no,
you can.
You can, but if there is bile flowing from above, or if there is some mucus, you may use suction in the beginning, not use the irrigation. Air has been used, carbon dioxide has been used by some people, but it is not of much value. We tried and we didn't find it to be useful.
So minimal irrigation if possible.
Yeah.
Okay. I think Dr. Rajendra from Mangalore is asking about biodegradable stents and the biliary tree versus a covered SEMS. What is the update on that? And similarly, Dr. Majid from Thiruvananthapuram wants to know about the role of drug-eluting, cancer drug-eluting stem cells in malignant biliary strictures. What is the
I left on the new design stents deliberately because that was going to take more time. So biodegradable stents keep coming and going. Most of the biodegradable stents are not possible to be put in through the endoscope. They are possible through percutaneously. But the one biodegradable stent came which was possible to put through the endoscope. Very difficult to introduce. the degradation doesn't happen systematically and can cause blockage when the fragments dissolve and cause temporary obstruction. So that's why it has never become useful for biliary system until we get a material which has got a very uniform degradability or absorption and doesn't fragment. We cannot use biodegradable stents in the biliary system. I think I have answered about the SEMS and uncovered SEMS amply in my talk. And as far as the drug-eluting stents is concerned, yes, they have been used in South Korea and China, paclitaxel covered stents. But again, the same thing. Now there are better modalities like RFA and PDT, which are more predictable, more evidence of their utility. So again, the problem with the drug-coated eluting stents was that the drug levels were found to be optimal only in the first 2 weeks. After that, the drug levels were not optimal. So they were drug-eluting only in the early phase and not later.
Dr. Jayanti from Chennai is asking, why is covered and uncovered SEMS making a difference in malignant obstruction?
It's because uncovered SEMS can lead to more cholangitis, and that's why survival benefit. When we are talking uncovered, this is only one study which showed there was some survival benefit with uncovered SEMS, while the covered SEMS have no advantage in malignant strictures, nowhere. Even we were using them in distal biliary strictures, but again, the evidence is not in their favor.
No, I want to put the question the other way. In a malignant obstruction, covered and partially covered did not make any difference. So theoretically, it's an advantage with the partially covered, no?
See, I'll tell you that what happens is the covering somehow leads to a lining which promotes sludge formation and stone formation. The biggest problem with fully covered metal stents, even when you put it for benign, is that they tend to develop stones above it, but they get cleared when you remove the stent. In a malignant stricture, somehow the incidence of stone formation is higher in fully covered or partially covered stents.
So you prefer to use only uncovered?
Only uncovered.
I think we have run past 1:30 and it's the lunch time. I think it's a high time to close this session.
I think we enjoyed, Randir. It's a nice update.
Absolutely. Wonderful
One statement I liked it from you is, nature itself has given bile duct 7 millimeter. Why should we bother about surgeons climbing 2.5 centimeter? That's a message I liked it, and nice deliberation and the very good interaction. I must thank Dr. Randir for a nice update, and ISG Dr. Saraswat and Govind for this wonderful opportunity from my side.
Thank you, Vivek, Govind, and TSC. It's always a pleasure to be with you, and thank you, and have wonderful what is left of the Sunday.
So thank you, Dr. Sood, again from all of us out here and by all the members of our society for a wonderful talk. And I also want to repeat the 2 words you used in your talk, that think and do, rather than do and think. And that's very, very important. It's not only for biliary stricture, but so important in total our practice. That think, plan, and do, rather than do and think and plan. So with this, thank you again. Thank you, Dr. Chandrasekhar, for agreeing to moderate this session. A couple of things before we close. That we will have a next session on 16th. We will not have an ISG masterclass. So because on 16th we have a midterm meeting of SGEI, and we requested all the members who are out here to join SGI meeting. And there are 2 days of meeting that is on August 15 and 16, next Saturday and Sunday. So we'll have a next master class on 23rd of August, and the topic of that will be again important: chronic pancreatitis, diagnosis and management. And this will be delivered by Dr. Manu Tandon from Asian Institute of Gastroenterology in Hyderabad. And second thing I want to say that we had a very brief condolence meeting out here today for Dr. Tandon. We had a condolence meeting at AIMS also 3 days back. At 4 o'clock today, there's a condolence meeting organized by the family of Dr. Tandon. And we have sent the link to all the members of ISC through your WhatsApp and through email. Maybe request to all the members if they can join the condolence meeting at 4 o'clock today in the afternoon. With this, Thank you again, and we look forward to see you on 23rd of August for a talk for next masterclass. Thank you, Yogita. Thank you, Dinesh, for all the technical support, and we see you on other side on 23rd of August. Bye-bye.
Thank you. Bye-bye.